Guys, this is Mobeen. We are talking about the pulmonology. The lecture today is about the pulmonary embolism. The topics that we will cover are going to be the epidemiology, risk factors, consequences of the size of the emboli, clinical signs and symptoms, labs, diagnosis, and why does the AA gradient change and what kind of a change do we see. I see lots of discussions among students and even in the pulmonology department, so that's an interesting topic to look at. And finally, why in the pulmonary embolism we find more of a hypocapnia instead of hypercapnia. So what is the reason for that? So we'll discuss that. Let's start. First of all, of course we have done this discussion before. Pulmonary thromboembolism basically is that mostly the emboli that are from the upper part of the leg, normally from the femoral vein, we are talking about the deep veins. We have done a lecture on deep vein thrombosis. This is a continuation for the pulmonary part of it, or pulmonary consequences of it. So normally femoral vein or iliac veins or even even inferior vena cava, there can be thrombi here, which, right, the definition of an embolus is it's a detached part of a thrombus that would be traveling to a remote site. So some piece of this thrombus are usually defined as these are the things that are attached to the vessel wall and they contain coagulation factors, white blood cells, red blood cells, fibrin, and so on. So imagine a piece of this thrombus breaks off and that piece travels to relatively larger arteries to reach the, larger veins, finally to reach the heart, and from the right heart into the right ventricle, from the right atria, from there to the pulmonary artery, and that is where the next things are, all the consequences which we should talk about. So that is the embolus. So this is the pulmonary thromboembolism. Epidemiology is this, that 95% of pulmonary emboli originate from the deep vein thrombi. So that is the importance of this. All right. Now, what are the risk factors? We have done that in the thromboembolism chapter, that the risk factors can be determined by the Virchow's triangle, where what we say is that we have, so the Virchow's triangle for thrombosis, it says that there are states which are hypercoagulability states, for example, pregnancy, surgery, long immobility, genetic factors, primary genetic factors like factor V Leiden and so on. Then there is the endothelium dysfunction and damage. And then there is blood flow disruption, so turbulent or stasis of blood flow. All of these things can lead up to thrombosis. So these are the risk factors. People who have these factors are at risk of thrombosis. So these are the risk factors. Now, what happens is the size of the embolus that is traveling and reaches the lungs decides or determines the consequences of it. Many times patients are actually having a shower of very small emboli that reach the lungs, and they actually have no consequence. They are so small, they get lodged somewhere in the blood vessel, in the pulmonary artery somewhere. Actually, I should not make these like this. So let's say here is the trachea. So this is the trachea, bronchi, and here is a alveolus there, here is another alveolus, one more alveolus, and I'm just going to draw this. So here, now the pulmonary artery that comes in, it of course starts giving on branches, and then finally branches are present next to the alveoli for the gaseous exchange, right? So now the size of the embolus would decide the consequence of the consequence in the patient. So very small emboli, sometimes they can come in, they get lodged somewhere in the blood vessel, and they are so tiny, they are so small that either they become dissolved, so dissolution occurs, or they become organized and they become part of the blood vessel wall, a small fibrin mesh appears on them and they just are inconsequential. So that is small size. Then can be the very large size where a big piece of this thrombus, has become detached. When this piece reaches here, it is possible that it would come and occlude and get stuck at the bifurcation of the pulmonary arteries. And this is called a saddle embolism. And this saddle embolus, if it occludes this area more than 60% or about 60%, then that would actually cause immediate back pressure on the heart, strain on the right heart, cause acute cor pulmonale, and the patient would immediately just fall and die. Literally sudden death. Patient won't even say that I have a trouble, just fall and die. And such patients may not even be found out that they had the pulmonary embolism until an autopsy is performed and they are looking specifically for this. So that is this saddle embolism. Now between the very small emboli that do nothing and this large embolus which can cause sudden death, one can have all sizes of the emboli. And based on what is the size of the embolus and how big of an artery is blocked, that would determine the consequences of the embolism. So talking about the clinical signs and symptoms, again it would depend what is the size of the embolus. So small microscopic embolus that did not cause a big problem or did not occlude the blood vessels a lot, no consequences. Now saddle embolism, that is the other extreme, can cause sudden death. Acute cor pulmonale would occur, right heart would go into strain because the blood is occluded here, blood is stopped here and the heart is trying to pump it, and the patient can die immediately. Now between these two, what else can happen? Let's say that this embolus is stuck in some blood vessel where there is significant size of the blood vessel is involved, and so this all blood supply here in this section, let's say, is occluded. Patient, normally it happens on the lower zones of the lungs. Patient may have dyspnea first of all, which is defined as the awareness and difficulty in breathing. So patient may come all anxious and having problems breathing. Dyspnea may occur. Tachypnea may occur, a fast breathing rate. Sometimes it can be so fast that patient exhausts their intercostal muscles by doing deep breathings, and you have to kind of paralyze them and stabilize them. So tachypnea may occur. Then it is possible most of the time, because the lower zones are involved, and normally what happens is that when a blood vessel is blocked, normally a wedge shaped area after that, the area of the supply, can become infarcted. Now remember that lung has double blood supply, so normally it is really difficult to create this infarction, because when the pulmonary arterial supply is not there, bronchial is present and that is still providing blood supply, so the tissue does not get infarcted. And the lung tissue is getting blood from oxygen from three sources. The oxygen is coming in from the environment, oxygen is coming in through the pulmonary artery, and then from the bronchial artery. So three sources. So normally it is difficult to create the infarction, but let's say there is an infarctive area, you would see a wedge-like infarction with the dark red exudate and raised area, and it kind of goes out and involves the pleural membrane, and there may be exudate. So let's say these are the two pleural membranes. You might see exudate on the pleura and inflammation in here, and maybe even hemorrhage in the pleura, and pleurisy might be observed as well. Now in this case, friction rub can be heard. And what is the friction rub? I'm going to try to, if you take a, let's say this is a balloon and this is the internal lung with the internal visceral pleura. So let's say it's that, and now it is, the visceral pleura is going to now rub against the parietal pleura, and it's going to create a leather on leather like feeling, sound, and that is called the friction rub. So friction rub may be present. At the same time, pleuritic pain. What is pleuritic pain? That when the patient is trying to take an inspiration, when he is trying to inhale, the receptors present here, there will be pain on the inspiration and the patient would not want to. And what would happen is that the chest movement would become limited because of the pleuritic pain, which will cause hypoxemia, which would reduce, right? The tidal volume would reduce, the ventilation rate would reduce, and hypoxemia can occur. So keep that in mind. We'll discuss that when we'll talk about hypoxemia. Fever can occur with this, and of course patient would have anxiety. Now one more thing that you might hear is the expiratory wheeze. So what happens is that when there is an infarction or when there is thrombus and the platelets are activated over here, what they do is there is local release of substances. What are the substances that are released locally? We might have serotonin, histamine, and most importantly thromboxane A2, which would cause severe bronchoconstriction. So these things can cause obstruction, they can cause bronchoconstriction, and so when the patient is breathing, you might hear a wheeze, an expiratory wheeze might be heard. So these are the clinical signs and symptoms. Now continuing our discussion, how about the labs? What happens when you get the lab work done? So of course guys, one thing, and we would explain this in detail little later, but remember this, normally the pressure of carbon dioxide, PCO2, is usually lesser than 33 millimeter of mercury. This is hypocapnia. Ideally the carbon dioxide level should be higher, but because of the tachypnea, hypocapnia occurs. Initially the levels go up and then they go down. Then the PO2 levels are usually about lesser than or equal to 80 millimeter of mercury instead of, and this we are talking about arterial, instead of about 100, 104. Of course this means respiratory alkalosis will be present. Of course this means that we have an AA gradient problem now, because hopefully the environment does not have a problem. We are talking about a person in the normal healthy environment. So AA gradient will be widened, and very importantly D dimers will be present. And why would be the D dimers present? Remember that D dimers are generated when plasmin breaks down the fibrin or fibrin monomers and polymers. When they are broken down by plasmin, that creates the D dimers which can be detected, and this is a sign that there is some thromboembolic activity going on. So of course if this is happening, then thromboembolic activity is going on and you can detect that. Normally to diagnose now, so moving from labs to the diagnose, I would explain this PCO2 level and PO2 level in detail today, a little later. So keep this in mind for the time being. Now diagnosis, what do you do? Chest x-ray. Chest x-ray can show two kind of signs. One is a cutoff sign. So if this is a blocked artery over here, then you would see a cutoff sign after that. Or there can be a Hampton's hump. What is Hampton's hump? Usually in the lower zones you might see pleural effusion, and you might see actually a wedge-like patch of opacity, shallow opacity, that is facing the pleural side. So a wedge-like infarct which is connected with the pleura, that is what you would see. So that is called the Hampton's hump. So you might see the Hampton's hump. Then in the labs, D dimer, again for diagnosis as well, D dimer is very important. The gold standard is pulmonary angiogram, but it is not necessary that that is readily available and everywhere available. So at least D-dimer and chest X-ray is something that should get you started. And then pulmonary radionuclide test can also be done, and it would show ventilation defects. So what would happen is that if you've given the dye and you're now taking snapshots, you would see that if there is a blockade here, then this area would not look perfused. The rest of the area would come perfused, and this would be not perfused. So these are the labs plus the diagnostic procedures. Start with the chest X-ray, start with the D-dimers, and then you can continue. Normally remember this, for pulmonary embolism, it is not a diagnostic, it is not a disease that you can just diagnose from the labs. There have to be clinical signs and symptoms combined with the labs and with the diagnostic features, and with a slew of signs and symptoms, clinical plus labs present together, you will assess and say, well, I think there is pulmonary embolism going on here. You would probably also know the patient's situation, that maybe patient has a knee joint surgery and the leg had been immobile for some time, or hip joint surgery and the patient has been. So you would also know the risk factors of the patient in addition to these labs, and that is how the diagnosis is made. Okay, so now we'll talk about the AA gradient change. So guys, if you are in a hurry and if you are comfortable knowing that the AA gradient will be widened and hypocapnia will be present, if you're comfortable with this much, you can stop the video here and move on. We do have some screens at the end of the video where you can see the saddle embolism or some of the x-rays. But if you're interested in understanding why the AA gradient is large or why the hypocapnia occurs, then please stick around and let's talk about that. So look, AA gradient widening. What that means is that if I make airway here, and this is one alveolus, another alveolus, I made that here as well in that way, apical area, middle of the lung, and the basal area. So let's say this is the apical area, this is, let's say, a couple of alveoli present here. I should make this better as well, so let's do that. And then let's say this is the lower basal part, so here is a couple of alveoli here, another alveolus here, then so let's say this is the situation in one lung. You know that, and of course it's a conceptual diagram, you know that the VA over Q ratio, ventilation perfusion ratio, in the apical areas is usually greater than 1.0. What that means is that these areas are more ventilated because the lungs are stretched, they are hanging from this area, so lungs are stretched, and so alveoli are bigger, more air comes in. However, because of gravity, blood is not present there, blood is gravitating on the lower side of the lung. So less blood is present, more oxygen or gases are present, so this has more ventilation and less perfusion. Normally the gradient is greater than 1.0. In the middle area of the lung, we say that ventilation perfusion ratio is about 0.8, which is taken as normal. And here what is happening is that the blood supply is slightly more than the gaseous or oxygen availability, or we say this is just the perfect match for the blood flow and oxygen availability or gas availability. So this is normal. And then in the lower parts of the lung, in the basilar parts of the lung and near the diaphragmatic surfaces of the lung, what happens is that the alveoli are smaller because of the pressure on them, plus there is more blood flow in this area because of the gravitational pull on the blood. So blood is gravitating in this area. So what would happen now is that there is, because of the smaller airways, ventilation is less, however perfusion in this area is more, and that would cause the ventilation perfusion ratio to become even smaller than the normal, and so normally about 0.6. So we normally say that this area is hypoventilated, this is sort of hyperventilated, this is normal, and the average is about 0.8, and we are happy with that. Now let's talk about it, that how do we end up having an AA gradient widened in the pulmonary embolism. So let's say that the blood vessel here, this blood vessel got blocked by an embolus. So as you can see here, this is a complete block. So the block can be of two types, a complete block, or let's use another blood vessel here and let's give this one a partial block. So why is that important? A complete block, now please write it down somewhere, a complete block will create anatomical dead space. What does that mean? Gas is present but exchange is not occurring. What will happen to the blood that was supposed to come in here? Blood will get redirected to the other areas. So we'll talk about that as well. A partial block would create a physiological dead space or shunt. What does that mean? What that means is that the blood will enter this area, but the flow is lesser than the amount of oxygen present that can be picked up by the blood. So now ventilation is more and perfusion is less, and that is sort of a shunt. Shunt means blood comes in and just goes out without picking up enough of the oxygen. Now where did that extra blood go? That would also get redistributed. So first keep this one thing in mind, that with the blockade the blood is going to be redistributed. One. Second, because of the blockade there is going to be local platelet activity which would cause release of thromboxane A2, which will then cause bronchoconstriction, and overall gaseous exchange areas will become limited. 2. Third, remember that because of the pleuritic pain, patient may not be moving the chest enough, and so the limitation in the chest movement might appear to create hypoxemia. Make sense? So there are multiple factors. I see students and teachers sometimes just hassling on one point, and student says, well, when this one alveolus or this one unit is not working, then the blood would go somewhere else, and why does it matter that the AA gradient would change? We'll explain that, but please remember the factors are multiple. Now let's talk about one more factor. I'm hoping that you're writing them down, that there is a factor of the blockade, then the factor of thromboxane A2, and now there is another factor, the factor of sluggish blood flow. So what happens is that as the blood supplies start getting occluded, there will be pulmonary hypertension. That pulmonary hypertension can cause back pressure on the heart, and there could be a chronic cor pulmonale or right heart failure developing. Now when the chronic cor pulmonale would develop, what would happen? The blood flow will become slower in the body. Slow blood flow would mean that tissues would have more chance to extract the oxygen. So now venous oxygen levels will drop below normal because of slow blood movement, slow circulation. Now would that not increase the AA gradient? Yes. Why? Because the venous oxygen level has gone down. So when that venous oxygen venous blood will come in here, it has to pick up even more oxygen to become normally oxygenated, and we have a diseased lung here. So these are the four components that together would cause a problem with the AA gradient change. Now these are all on the blood side. There is component on the alveolar side as well. Look, when oxygen is coming into this area, so let's say oxygen comes in here and we have a PaO2 of 100 or 140, and then out of that there would be finally there'll be 100 or 104, and there'll be gaseous exchange and so on. But isn't this true that the oxygen that reaches those alveoli where there is not much perfusion, that oxygen will just get back out? Now in all the other alveoli, oxygen has been extracted, has been taken up in the blood. So oxygen that is going back is lesser in pressure. However, this one has greater pressure because oxygen did not get out. When the greater pressure of oxygen or higher concentration of oxygen combines with the lesser concentration of oxygen, the final oxygen that comes out is going to be PaO2 is going to be higher compared to a healthy person whose alveoli are working and even this oxygen concentration is lesser. So now that is the fifth component. So what you are seeing is that expired gas or alveolar oxygen will show an increase in oxygen level because not a lot of oxygen is extracted. That is one. And the venous side, the blood side, would show a reduced oxygen because of these components that there is blockade. And there is limitation in the circulation because of thromboxane A2. And there is reduced oxygen levels in the body anyways because of sluggish blood flow. Now let's talk about this. Why would this cause reduced oxygen pressure in the blood? Here's the deal. Blood that is not going into this blocked area is going to be redistributed. That means it is going to go into the other areas of the lung and pass from there. Now, it is entirely possible that the blood ended up going into another blood vessel and this quantity of blood was not big enough and that blood vessels or other areas, it went and perfused them and it got its oxygen and it's happy and you don't see a lots of change. Although you would still see PaO2 increasing because of this. So 100% of the cases you would have AA gradient widened. However, this is also possible that when blood comes to other units, it might be redistributed in the areas of low perfusion, ventilation perfusion, low ventilation, let's say in the other lower areas. So it is not necessary that the redistributed blood is going to pick up oxygen. Secondly, it is not necessary that you send a lot of oxygen in this, a lot of blood in this alveolus and all of the blood will become saturated. So redistribution will actually cause reduction and shunting. Shunting means the venous blood comes into the lung and just gets out and it is not perfused. So as soon as shunting occurs, that would mean the oxygen level in the arterial blood will be lesser and oxygen level in the alveolar side is greater, AA gradient got widened. So that is what happens with the oxygen levels and that is the reason for the AA gradient to be wide. Now let's talk about the final thing, and that is, why do we end up having hypocapnia? Look, here is what happened. Part of the lung is not functioning. Carbon dioxide coming in from the body doesn't have the route to get out from that part. So ideally carbon dioxide level should increase. Yes, it does increase. So that means hypercapnia. So you caught me. Hypercapnia, not hypocapnia. Well, yes, hypercapnia. But now there are two more systems that would work. One system is medullary. Remember we did the respiratory centers. So in the medulla, the respiratory center, when that would see the pH is changed because carbon dioxide is increased, carbon dioxide increase would do what? Carbon dioxide plus water, that would give this and this if I summarize this, right? So this pH acidity would occur. That would trigger the medullary respiratory centers, and what would happen? Tachypnea or increased breathing rate would be done. Now when the tachypnea occurs, when the patient starts, what is he going to do? He is going to wash out the carbon dioxide. That is why the hypoxemia would occur. That is one reason. Not hypoxemia, hypocapnia. The other reason is that the J receptors, remember that there are J receptors present. J means juxtapositioned. So these are the receptors that are present near the alveoli and the blood vessels. So when there is a damage, there are toxins and there are substances like serotonin and histamines and thromboxane and irritants are present, and even there is possibility that the surfactant is not produced because there is not enough blood supply, and it is possibility that atelectasis is happening and the blood alveoli are damaging and they're getting collapsed and there is local damage. All of that would irritate J receptors, and J receptors cause a reflex tachypnea as well. So two things would cause increased in breathing rate, and both of them would cause hypocapnia. So please remember, respiratory alkalosis would be seen with that low oxygen, low carbon dioxide level, low oxygen level, widened AA gradient, and D dimers will be present. So one more point about the right to left shunting. So what happens is, we know that there are some genetic problems where it is possible that the foramen ovale is patent, right, and the normally left side shunts to the right because of higher pressure, normal, right? However, in this situation, when the pulmonary hypertension occurs, when the cor pulmonale, chronic cor pulmonale occurs, then what happens is that the pressure on the right side increases enough sometimes that it would start actually reversing the shunt, and so blood, instead of shunting from left to right, is now going to be shunting from right to left. This is an interesting situation because there is a shunt happening here, that is pulmonary right to left shunt, and that can actually be in the patients with the patent foramen ovale. In these patients there could be a cardiac shunting as well. And you know what, how as a doctor you can exaggerate this situation. Let's say you are not aware that this is happening, you are not aware that the patient has a patent foramen ovale. Hopefully you are aware, but let's say you are not aware. You look at this situation, how do you treat this? You try to give them the positive end expiratory pressure, you try to paralyze the muscles and start giving them the ventilator. Now when the positive pressure, so this lung is already in hypertension, this lung is already having back pressure, due to that there is already shunting, you add further pressure onto the lungs, what would that do? Increase even more, cause even more hypertension in the lungs. That would push even more blood back, and that blood is going to start shunting. So you can actually exaggerate, or a doctor can exaggerate accidentally, unknowingly, incorrectly, mistakenly, the shunting in the heart from right to left. So it is possible that there is a right to left pulmonary shunt which is accompanied by a right to left cardiac shunt. Thank you very much.